Okay, this is an interesting case of a 66-year-old female who presented via ambulance for altered mental status and a possible stroke. History is limited to just the medics. She was last seen normal the night before at 11 o'clock and then arrives at about 7 a.m. And family noticed that she was unresponsive that morning, so they called an ambulance. Initial vital signs in the ED are blood pressure 200 over 128, pulse 110, respiratory rate 24, temp 99.4, and O2 sat is 99% on 4 liters nasal cannula. EMS also reports she had a heart rate of 160 en route, and apparently they thought she was in SVT and gave her adenosine twice without improvement. She's unresponsive. She's ill appearing. She does not withdraw to pain. She has a rightward gaze preference. She's noted to be weaker on the left than the right. She's mute, aphasic, and her GCS is 5. EMS also points out that the patient had urinated on herself. The son arrives. He says that she drinks a bottle of vodka every day, been sick for a few days with decreased food and water intake. Denies a seizure history, but then afterwards says maybe she did have one because of a UTI in the past. He was unclear. She does have a history of depression, suicide attempt, TIA, hypertension, and alcohol use disorder, and then a remote history of breast cancer, status post mastectomy, and chemotherapy. In the emergency department, her initial labs show basically a normal white count, platelet and hemoglobin, sodium, bicarb, glucose 230, creatinine 1.6. She's got an AKI. She's very acidotic. Her pH is 6.99 with a CO2 of 70. She has a stroke alert, essentially. She has a CT, CTA, or angio of the head, neck, and a perfusion study, all of which are normal. This was her head CT. There's an MRI done in the ED in the sort of quick time frame, which shows questionable subtle flare hyperintense signal in the medial right temporal lobe, parahippocampal gyrus, faint diffusion signal abnormality. The chest X-ray, which is normal. Because of how critically ill she is, she's intubated with etomidate and rocuronium. She's loaded with Keppra for presumed or possible seizure. She was given a total of 12 milligrams of Ativan during her time in the emergency department for possible alcohol withdrawal, which seemed high on the differential. She started on an Esmolol drip for hypertensive emergency, and she received broad spectrum antibiotics as meningoencephalitis could not be excluded, or she was admitted to the ICU. So, what's the differential diagnosis at the time of admission? Well, it includes subarachnoid hemorrhage, which we've ruled out, ischemic stroke, which we've essentially ruled out with the MRI, severe electrolyte derangement, infection, hypertensive emergency or posterior reversible encephalopathy syndrome, congestion or some kind of toxidrome, alcohol withdrawal seizures and delirium tremens, seizures and status epilepticus, herpes encephalitis, paraneoplastic encephalitis. All right, so buzzkill, she had focal temporal lobe epilepsy as a new diagnosis. Causes include hypoxia, head trauma, hippocampal sclerosis, which we'll talk about, most common, traumatic brain injury, gliomas, AV malformations, cortical malformations, encephalitis, and genetic abnormalities. Essentially, two forms. There's the mesial temporal lobe epilepsy, or medial side of the temporal lobe. It is most common. It involves the innermost structures of the lobe and is associated with hippocampal sclerosis. And then there's a lateral temporal lobe epilepsy, more rare and associated with genetic or acquired structural lesions. And about half of patients will have bilateral epilepsy. They can present differently, which makes diagnosis a challenge. One presentation is focal, meaning the lesion is focal and the seizure is focal. They're awake or aware. They can be sensory, emotional, and cognitive, your classic tonic-clonic activity. And there's no postictal state. They can be focal and impaired, where they lose consciousness and can have focal lesions. The motor symptoms can be motionless with dilated pupils or automatisms. Then they can have tonic-clonic or the so-called grand mal seizure if both hemispheres are involved. Workup is typically started in the emergency department when they present for their initial seizure. That includes neuroimaging, including CT and MRI, to look for structural lesions. On MRI with hippocampal sclerosis, you can find a reduction in hippocampal volume, increased signal intensity on T2 imaging. Then EEG, of course, is the gold standard, helps localize the lesion, focus, and elucidate the neural network. So here's a coronal MRI of a patient with hippocampal sclerosis, has a positive radiology sign or positive arrow sign. On the patient's on the screen left, patient right, you can see some increased signal on the medial side of that right temporal lobe, consistent with hippocampal sclerosis, the focus of the lesion in our patient. Treatment includes anti-epileptic drugs. There's really two flavors. There's the old or first gen, the first column, and then there's the modern generation and the newer ones. And those are preferred, but of course, often more expensive and harder to get for your patient. In refractory cases, you have to consider temporal lobe surgery, which comes in many flavors, but the two most common are anterior temporal lobectomy, selective, try to say this, amygdalohippocampectomy, AHP. Complications include irreversible neurocognitive decline, right? The more you seize, the more you're burning through those neurons. And then something interesting called SUDEP, or sudden unexplained death in epilepsy, which is rare, accounting for less than 0.1% of cases, and is a death that occurs in the absence of status epilepticus. So the patient in our case was diagnosed with focal temporal lobe epilepsy of uncertain etiology. At the time of her discharge, the working etiology was either paraneoplastic or associated with cancer or autoimmune, and both of those panels were pending at the time of discharge. She was started on levetiracetam and lacosamide while in the hospital. Other workup that she had while inpatient included a lumbar puncture, which was normal, CT chest, abdomen, and pelvis looking for tumors. She was found to have a T12 compression fracture, which was probably, of course, incidental, but put in a thoracolumbar orthotic. And then a hypertensive emergency and AKI both resolved with the appropriate care. When she left, she was alert 90 times 3, and she did not follow up with our neurology service, but she was admitted to a psychiatric institute about a month later for suicidal ideation. 3 key points. The first is temporal lobe epilepsy is highly variable and often unrecognized or misdiagnosed on initial presentation. This was the case in our patient. It is among the most drug-resistant forms of epilepsy, and some patients are excellent surgical candidates when the anti-epileptic drugs are no longer working or aren't working at all.